Good evening, and thank you for this opportunity to present to you today. At ECHO, our mission is to democratize implementation of best practice for healthcare and education for underserved people all over the world. We have a goal to touch the lives of 1 billion people by the year 2025. In 2001, I was seeing a patient in my clinic, and in the room was a 43-year-old woman. Along with her was a 14-year-old boy and a 9-year-old girl. And I asked her, how can I help you? She said, I have hepatitis C and I'd like treatment. I said, how long have you known you have hepatitis C? And she said she had known about it for 8 years. So I said, why did you not come earlier for treatment? And she said, I live 200 miles away. I had called your nurse. There was an 8-month wait to see you. And I would have to make 12 trips while taking these injections and pills. And there was no way I could do that. So I decided not to take treatment. So I said, why did you come today? And she said, I'm having pain here in the right upper side of my abdomen. I got worried. I did an ultrasound of her liver and found she had a cancer of her liver, which was slightly smaller than the size of a tennis ball. And it was too late to treat her now. She was not a candidate for resection or liver transplant. And she passed away 6 months later. And I asked myself, why did she have to die in a situation where I knew how to treat the disease and the medicine was available? And the answer was she died because the right knowledge didn't exist at the right place at the right time. And we have estimated that tens of millions of people die all over the world because the right knowledge doesn't exist at the right place at the right time. So the key strategy to help 1 billion people in ECHO is to move knowledge instead of patients and providers. Hepatitis C is a particular area of focus for us because we know that DAAs-based treatments are highly effective for curing hepatitis C. They significantly lower the cost of treatment now because these medicines are available very inexpensively in low-income countries. But the challenge we are still facing that very few of the people with hepatitis C in the world are diagnosed and only a small minority have been treated. But if we were able to improve the diagnosis, get everybody diagnosed and treated, we could save millions of lives for very low cost. This is an unprecedented opportunity for humanity. So going back to that patient that I saw, in 2003, there were 28,000 hepatitis C patients in New Mexico. Only 1,500 had been treated. And I developed the ECHO model to get treatment to everyone. The model is based on 4 ideas: amplification. How do we use technology to leverage scarce resources? I went around the state of New Mexico and set up 21 new treatment sites. And each site was run by a doctor or nurse practitioner, and I gave them my protocol, but not a single one of them was willing to treat hepatitis C with interferon and ribavirin. So I asked myself, how did you become an expert in treating hepatitis C? When I did my fellowship in Boston, Massachusetts, I would see a patient present to my professor, see another one present to my professor. And after 2 years, they started calling me a gastroenterologist. So I said, aha, I'm going to use this model to create new hepatitis C specialists in New Mexico so that everybody could get treatment and use a web-based database to monitor outcomes. So we started using our technology to train physicians, physician assistants, gave them our web-based software. And in 2003, conducted the first knowledge network clinic where all 21 would join in an interactive video network. And in a typical clinic, they would present patients to each other. And to us, we discuss about 8 patients, and I'd give them a 15-minute lecture on some aspect of hepatitis C. And what we found was that in 1 year, they became experts. The wait in my clinic fell from 8 months to 2 weeks. We published this paper in Hepatology showing their ability to identify suitable candidates for treatment went up dramatically. Their ability to assess severity of liver disease went from 3.2 out of 5.5. Ability to treat hepatitis C went from 2 to 5.2 out of 7, where 7 was an expert who can teach others. And they became local consultants so that they could accept referrals. Their ability to serve as a local consultant, 2.4 to 5.6. Overall competence increased dramatically over the course of 12 months. And the interesting part was they found that this enhanced knowledge, being well informed and achieving competence, was beneficial for them, not just for their patients. We finally did an outcome study in which we demonstrated that these rural doctors could produce the same level of care as university specialists. And this is our paper in the New England Journal of Medicine showing that the cure rates for hepatitis C were the same. So what are we trying to really do in ECHO? We start off with declarative knowledge. How do we treat hepatitis C? And then in these all teach, all learn networks, we convert this into procedures. What do they have to do? Which tests do they have to order? What drugs to prescribe? And we help them do that again and again with iterative guided practice until they become autonomous and don't need us anymore. This is Albuquerque, where I live in New Mexico in the Southwest United States. This is our hepatitis C project. Of course, after we showed that hepatitis C could be changed, we treated more than 10,000 patients. But the interesting thing was people told us it could be used for a lot of other things. Now we use ECHO for more than 70 different healthcare conditions in 179 countries for diseases like autism or cardiology or geriatrics or HIV, addiction, psychiatry, etc. This is our Veterans Administration network with 11 university hubs connected to 600 clinics. Our mission in life is to train other universities and other academic centers to do ECHO, to democratize their knowledge and exponentially improve the capacity to deliver best practice care for hepatitis and for any other chronic disease they're interested in. In the United States, we have taught 332 academic hubs. All the major universities in the United States are ECHO partners and have launched ECHO projects in the all over the world. We have 602 hubs, leading universities like the University of Cape Town, Infection Control Africa Network, and others. We also partner with World Health Organization African region for the COVID-19 response. Currently, we also have 21 super hubs in the world, which are hubs that train other hubs. We came to Africa first in 2015 to improve access to HIV treatment. We wanted to get 200,000 HIV patients on treatment. And you can see in Africa, we are doing projects on HIV, quality improvement, global health security, infection control, surveillance, quality improvement in surgery, cancer, etc. And we have many, many projects in Africa. For example, in Tanzania, we'll have 5 hubs. We also partner with the Africa Union and African CDC for implementing international health regulations. 9 country governments, ministries of health have already signed collaborative agreements with us, which include Ivory Coast, Tanzania, Egypt, Ghana, Uganda, Sudan, Lesotho, Namibia, and Zambia. And for hepatitis C in the United States, we have 34 academic centers that use ECHO. Hundreds of thousands of patients have been treated. Worldwide, we have 53 academic hubs that have launched hepatitis C ECHOs. So the potential benefits of the ECHO model are improved quality, safety, rapid learning, reducing variation in care, improving access for underserved patients, and workforce multiplier effects. Here is a paper from Argentina that showed that they mentored 25 providers and had 94% SVR rates with ECHO. This is the VA ecosystem showing that ECHO for cirrhosis was able to reduce mortality by almost 50% for cirrhosis when they compared doctors who were participating in ECHO and doctors who were not. This is another paper from the VA showing that they could increase access to hepatitis C dramatically with ECHO. This is a paper on hepatitis C from Punjab in India, enrolled for 51,000 patients in 22 district hospitals. There were no specialists and got a cure rate of 92.7%. This is a picture of that. They also were able to show that this was effective for patients who use drugs. Overall, we have 328 peer-reviewed publications showing that echo work, 46 showing that patient health outcomes improve. So why do we need echo for hepatitis C when the treatment is so simple? Even today, current primary care all over the world is having difficult time interpreting hepatitis B serology, accurately making the diagnosis of cirrhosis, screening for liver cancer, managing complications, assessment for liver transplants, and they need mentorship, and echo projects could do that. So our conclusion here is that new care models that integrate technology, bring access to HCV care patients, can actually be a game changer for the world by bringing more access for hepatitis C treatment at very inexpensive rates. What makes echo work is team-based care. Task shifting is the idea of making every human being working at the highest level of his human potential, and that requires guided practice, mentor-mentee relationships. Echo is also a social network that produces joy of work. Echo has been expanding rapidly. In 2019, we had 231,000 learners. In 2020, that shot up to 1.3 million learners in the world. And I'm inviting each one of you to join us. I want to end with a quote from Albert Schweitzer, who was a physician working in Africa. He said, "I don't know what your destiny will be, but one thing I do know, the only ones among you who will be really happy are those who have sought and found how to serve." And I encourage you to reach out to me to set up echo projects in your community. And thank you very much for this attention.